Well, welcome back. So we do have a few changes, obviously, to the agenda since John Auerbach's going to be leaving. And so after our panel discussion, somewhat treat it with any questions you may have at the end of the day, ask them now, since we'll do our panel, and then we'll take a break, and then we'll do the breakout sessions again, and we'll be finished at the end of the breakout sessions rather than come back here for a closing remarks. And I know everyone's disappointed that you can't stay all day, so that's okay. So now it is my pleasure to introduce Dr. Jerry Milstead. Dr. Milstead is a retired dean from the University of Toledo. She's been dean other places also. She's in the 6th edition of her textbook on health policy. She worked in Washington, and Senator, I can never say his name, from Hawaii, Inouye. And her textbook is sold in 6 continents. It's internationally recognized. She, as a policymaker, her PhD's in policy. You can read in your brochure the tremendous things that Dr. Milstead has been doing over time. So we are delighted that she's here as the moderator for this fantastic panel. And when someone finds Larry, we have to get him up here. But so he'll come. Anyway, Jerry.
Thank you. Thank you. It's good to be here this afternoon and to see all of you who have stayed, and we do appreciate that. We have an esteemed panel, and informally we will pipe up with whatever particular areas of interest we have. But since there is no set form, we're not going to have a presentation from each person on the panel, but I will introduce some ideas, some concepts, and the idea of this whole panel is to look at barriers to some of the practices and some solutions. Now, we've spent all day so far doing that because we've had a lot of people who have told us their success stories, and with that come some of the tearful parts of it. But there are some pieces that we may not have addressed, and so I'm going to start with payment reform. That's a heavy-duty one. Nobody likes to talk about it because, honestly, I think a whole lot of people don't understand, and most of us don't understand how payment is done, how it's made, how it's figured, how it's even thought about. So I'm going to ask the panel if you have had any experience with payment reform, in what form, and what were your barriers, and how did you find a solution if you found one? Does anybody want to start out with that? All right, Craig, go ahead.
Thank you, John. Good afternoon. First of all, I want to congratulate you for having the largest healthcare panel in history of America. Really impressive. Equal number of people up here is out there. My name is Craig Brammer. I'm with the Health Collaborative. It is sort of like the Chamber of Commerce of the health sector here in Greater Cincinnati. It's a very, very special organization in that most communities don't have a team of 60 people really focused on improving health and healthcare for the region. About half of our work is digital, so HealthBridge was merged into this organization, so we move about 15 million clinical results each month and other work. But one of our big initiatives is running what has now turned out to be the largest ambulatory payment model in the country with 14 payers, including Medicare and Medicaid, and now 560 some odd practices. I think you heard from Dr. Shank earlier. I don't know how much he mentioned about that member of our team. And I believe an important barrier to team-based care is fee-for-service, and an important solution to team-based care is value-based purchasing. And the obvious point there is paying for outcomes instead of cycles. And so we see that a lot in these initial practices where over 3 years, ambulatory sensitive admissions were reduced by 23%, over 500,000 patients, which is significant. And when we dig into, when our team digs into what actually happened, you just find a lot of creative use of team members Interestingly, the number of primary care visits declined by 10%, and we would have expected this is a primary care intensive effort, so you'd think it would go up. But what we learned over time is that that other members of the team interacted with patients in non-traditional ways. So these are asynchronous interactions electronically or calls or home visits, and it's a real way to leverage teams. And you know, I believe we're in this era of network medicine where you can't practice in solo anymore. You have to be part of networks, digital networks and social networks and referral networks. And so we're even seeing providers starting to extend beyond their own organizational structure to extend their team to, you know, like Talbot House or some other organization that addresses social needs of their patients in a more sophisticated team, contractual sort of way.
Anybody else want to speak to that? Pat, do you want to talk about how, were there any problems in convincing Medicare, for instance, or in convincing any part of the government structure about going to value-based, or do you think they initiated it?
I'm still working on that, Jerry.
All
Well, no, I mean, no, I think it's a work in progress. I mean, it's the practice. I visit a lot of practices in Columbus that work with first and second year medical students, and in addition to this fourth year stuff that we do, and they haven't seen a lot of change. I mean, they're still in a rat race. See, it's how many patients you see, you know, productivity, quantity over quality, and so, you know, the Cincinnati model that everybody's watching and now going statewide is, you know, will that actually happen? Because if you can, you know, 10% decrease in your visits is more time for teaching, more time to get home on time. And so I think, you know, I was talking to John at the break. 20 years ago, I thought capitation was going to be the answer to everything, because you would just get paid per, you know, you looked at what was happening with capitation, and you, as a practitioner, you're kind of thinking, well, I don't know, because I'm so used to this, see people, you know, that's how you make a living. But I thought to myself, boy, if I got paid per patient per month, I don't really have to see them. We can have these asynchronous contacts. We can talk to people. We can hire people. So no, I think that, and through OPC, PCC, those practices that were in the, you know, the initial 44 that were transferred across or transformed to medical homes around the state, only about 30% of them have seen any increase in payment. So it's still, so yes, I will continue to work on Medicare, Jerry, just to make this happen. No, I mean, there's a lot of things that have to be, you know, accomplished for that to be where it needs to be, because that's the answer. I mean, you got it paying for value and quality.
That transition is difficult. John, you have something to say?
Yeah, I mean, I think that one piece of this is also clarifying a value for what. Because it isn't possible to improve health on everything. You know, you have to make choices about, in terms of when you have a value-based contract, what are the measures going to be? And there I do think it really matters that if you pick the right things that you want to change. You know, when I was involved with some of the payers, for instance, you know, understandably they wanted a value-based contracting where they were already doing well, and so you weren't really going to see a whole lot of improvement as a result of value-based contracting, but you're going to be guaranteed payment, and I think that I would say, to come up with the right quality control measures that you're going to prioritize in a value-based contracting needs a really good process, and a process that involves knowledgeable clinicians in the community, public health people in the community who know what the health issues are, and consumers at the table. I think you really need a process to think about that carefully, or else we won't necessarily see the kind of improvements in quality that we're hoping to see.
Anybody else want to add? Dr. Crumpton? No? Good. I think, like every law and regulation and every type of process like that, it's not a finished product when it's marketed, and it has to evolve. The is a prime example. Everybody thought, well, this is the law and this is how it is. And there were tweaks all along the way. People weren't happy with some pieces of it, so it got tweaked. That happens with every law and oftentimes with regulations over time. So this is a concept. It is seems to be catching on, seems to be a valuable concept, but the details won't be worked out quite as easily. All right, let's look at electronic health records. We've mentioned that, we've talked about it in various breakout sessions, and of course you've all heard of meaningful use. How has meaningful use, do your practices use electronic health records in a way that you can actually get some meaning for them?
Sure.
Sure.
So I want to say some things about the electronic health record in general. One of the worst, best things that happened with the electronic health record for those of us who were there during the transition, because helping people move from a paper-based system to an electronic system, and especially based on technology skills, I think has been the challenge. But I think we're now getting to the point of beginning to see the advantage of that. So because we are a federally qualified health center, our meaningful use is extracted from that data system, and it's been very valuable. We couldn't have done the kind of evaluation of meaningful use without that, but it also comes at sort of a cost that we're recognizing. One is it slows down providers in doing patient care. And so the numbers of patients they were able to take care of, they feel like they're spending so much time documenting in the records, and some people have done some great innovations around that. And so I think we have to be mindful of the stopping and documenting. The other is that mostly electronic health records have been created and evolved by people who aren't on the front line providing the care. And so the data extraction process has been a bit of a challenge. So an example is colonoscopy. So in our system, colonoscopy can only be detected by our system if it's written in surgical history. And that's a difficult thing to achieve, that level of consistency across the board with providers. And it took us some time to figure out that that's where the limit was. So I think that the electronic record has powerful abilities and opportunities, but we're going to have to sort of look at the ways in which we're putting the data in but maybe missing it. And I think that's something that's going to be an important part of seeing what change we're actually affecting.
Larry?
So I just like to have fun. So remember, I'm a social worker. I am not a clinician, and I'm not an administrator. But I do have a perspective on innovation, and I think we've created, through the electronic medical record, something that is now the main obstacle to innovation. We're really good at getting data out of these systems, and that's really cool, and people who like to play with data are having a heck of a lot of fun. The folks in the front line, however, are identifying current electronic medical records is one of the most noxious parts of their lives, especially when they're documenting late into the evening while at home and trying to catch up with things. We've created the perfect trap. We've aligned data and input systems with metrics that don't matter, with a payment system that's determined to drive everybody using the alignment of those things. And so we have to, in my opinion, we have to really relook at this. These current provider organizations have spent a lot of money, which is called overhead in most businesses, investing in these things, and they don't want to give them up or change, because if they have to invest that kind of money again, particularly primary care practices, it costs them a heck of a lot of money. So we have to figure out a better way to do this, both in the issue of how the data goes in identifying metrics that actually matter. I call it meaningless use. We keep trying to count things because they can be counted, and now we can count them really fast, and we can drive the clinicians to have to check the boxes in order to get paid. I mean, it's a perfect storm. So I know it was an advancement, and I think, Dr. Compton, you're exactly right. It's an advancement with a heavy price, and I think we need to back away and take a look at what we've done and just sort of break the parts up. Maybe disconnect, hopefully with the value-based payments, we'll disconnect the drop-down boxes from the payment. So clicking more boxes to get more money, but it's going to take a while to get the mice to stop hitting the little bar to get the thing to come down.
Janice, you look like you're ready to pop in there.
Yeah, I'm gonna, hello? Yeah, I'm gonna disagree. You know, when we went to electronic health records, from paper charts on a wall, you could not identify who needed your special attention, who had A1Cs greater than 9, who targeted your care. So when we're talking about giving the best care to the most people, we need to be able to target who really needs it and who's perfectly fine on their own. So when we actually went electronic, and we were one of the early adopters, all of a sudden now you have the data that you can direct your care to the people that need it the most. So, you know, early on, people were like, oh, the system, the system, the system. Now, if we would interview someone and not have an electronic system, there would be no student who would come to us. There would be no new practitioner who would come because they're so used to it. So, you know, I think the hard part is you have to have rules, and once you have rules, then they live with them. We have 24-hour sign-off. It has to be signed off in 24 hours. I mean, our goal is that you're signing off on that patient's chart when that patient is done and being discharged. So I think there is some discipline that has to go in it, and people don't always like that, especially when they've been in systems that have allowed them to do things their own way. You know, the stack of charts at the end of the night, and as a nurse who's worked with physicians forever, that's what they hated most. So forcing them to kind of finish it when you finish the patient is sometimes a hard thing to get them to change to do, but once they do it, and now we're connected to the HIE, which is where the real power happens. When you have electronic health record compared and connected to the HIE, which can tell you when your patient was in an ER, when they were being discharged, what pharmacies they were going to, what services they were getting that you didn't know about. They might be going between multiple people. There's the power in really managing the population. So though it's growing pains, you know, that looking for a record, I mean, anybody ever worked in the front office and you can't find the missing chart? Maybe I'm too old. But there are always struggles, but I think the power in the electronic record has made us know what quality is.
You wanted to say one more word and then Pat?
Just very, very,
Close.
I think I disappeared. Oh, there I
No,
am.
just get close.
Okay, so and I wouldn't go back to the paper system. I would not recommend that at all. But I will tell you this. Joe Ketcherside is a retired neurosurgeon in Memphis, Tennessee, and he created an artificial intelligence program that reads the electronic medical record. And what he found is that the clinician's soft note, the data that's in that, which speaks to social support and other kinds of things, is the best predictor of who's going to become a high utilizer in the next 6 months than the number points. And that was my comment about the meaningless use, the data points. So I do think we need to, we're in the electronic world, there's no question. The question is, are we going to be driven by primarily billing systems, or is it going to become truly something that aligns better with what we call artificial intelligence?
Doctor? Oh,
Can I
all
just jump
right.
in? Because, you know, we're working on the comprehensive primary care, and you're absolutely right. Risk stratification is based on the billing end on the back, basically what buttons you hit. But what we're developing is risk stratification within our electronic record so that the care teams also click buttons that we design as a template, and then we develop our own risk stratification, which may or may not be different from what the managed care plans or the payers do. The payers are 6 months after the fact. So we all know patients that we see today that are train wrecked that 6 months ago were perfectly fine. So we have to have the care teams be able to make those calls clinically and be able to change that risk factor if we want them to be able to actually impact the care people are getting. And you're right, things that are drawn from clicks on a button may not represent where that patient is right now, but the EHR allows us to develop those templates within it and give that power to the care teams to do that.
Dr. Eckler?
Yeah, I think the devil's in the details on EMR. We're not going back, can't go back. I still go to offices that have paper charts. I mean, visit them. It's interesting. It's also interesting to ask a physician what it's like for their visit, their first visit to their doctor now that they've gone electronic. And they go like, I had multiple patients say, I want you back the way you used to be, you know. And so, and I also learned another thing, a thing called a registry function, where the hemoglobin A1Cs above 7 are automatically expelled with the push of a button. Well, the system that my employer got didn't have that. So we're still going through charts looking at, how about picking the same electronic medical record system for my office that was a block away from my hospital? Okay, no, let's have two. Let's have two separate systems, and then you can figure it out, okay? You'll be as fast as you ever were after 6 months of using this, and you won't believe that you ever lived without electronic medical records. Well, I had 3 years, and I still never got as fast as I was and never believed. And then all systems were going to be completely interchangeable by the fourth quarter of 2014. Okay, that was the, and so that was the carrot. That was because if I could get complete interchangeability or interoperability, I'm in business. I can, you know, I got 4 hospitals within 3 miles of my office to be able to get the record. And so I went, I'll put up with this. I mean, you know, if I get complete interoperability, but no registry function, not able to quickly track who. So it's you know, and I would ask surgeons to take medical students because their letters to me documented a 12-point physical exam, okay? And I go, well, obviously you can teach physical exam. I mean, I get letters from you. You've done a 12-point exam, including gait and cranial nerves and everything. And they go like, well, not really, you know, and because it's just click, click, click. So for billing, it's wonderful. And so again, you can't go back. But yeah, when they have artificial intelligence and decision support and can help you really track through and sort through, what was amazing to me is the narrative. My narrative was the best part of the chart because that was me interpreting what that patient said. And then about 6 months into this, they go, you know, we can't bill for any of that. So all of this, all of the stuff that really describes the patient and what their worries are and concern, the records just don't capture that. So I mean, and then I got to where if I just think it, it goes into the chart, okay? But then things are like, I'm hungry, you know, or I really don't like you. You know, I mean, you just start to worry about, you know, is it, maybe you don't want that much detail, but there's got to be a balance. I mean, the logistics, the details, and then some doctors have systems that they just couldn't live without. But I talk to a lot of physicians that do charts every night at home after the kids are in bed. Mm-hmm. And I just, oh, and by the way, thanks for taking this medical student. I mean, thank you. Thank you for doing that for free. We appreciate that, you know, after they've told me what it's done to their, so the balance, it's kind of getting this all worked out. But the data that you can collect and retrieve and how can you do population health without being able to compile that? But it has to be a system that lets you do that. And there's like 250 different vendors the last time I checked. And so anyway, sorry.
From a little bit different perspective, we do have a pharmacist on board. How have electronic health records impacted you and your practice and the pharmacists that you work with? And I'm not sure if you're a pharmacist or a PhD in pharmacology.
Pharmacist.
A pharmacist, all right.
We'll try this.
Just get up close.
Yeah, so I'm practicing pharmacist, worked at Christ Hospital, and I'm an associate dean for professional education at University of Cincinnati College of Pharmacy. So I kind of wear 2 hats. One is the curricular hat and working with interprofessional education, which I think we'll talk about a little later. From a practicing pharmacist standpoint, I can see that, and I was a pharmacist prior to electronic health records and then certainly after, practicing. And there are a couple of really strong benefits, I think. One would be medication reconciliation. So for anybody that works in a hospital setting, or even really anybody that works as a clinician, period, when a patient comes into the hospital and we start them on their medications, most of the time it's not right. And when they leave the hospital and they're discharged on their medications, most of the time it's not right. And so electronic health records, and hopefully that's not surprising, I mean, that really is the way it is. And so electronic health records has helped the detective work that goes into reconciling a patient's medication. So I can open the chart, find out where they get their meds filled, get a phone number, call that pharmacy, get things situated, and then talk to the patient with anything else that I might need information from. So it might take 2 hours to reconcile somebody's home medications instead of 3 or 4 that it used to take. So I think that's been a benefit. A drawback is that med list follows the patient around every time they're admitted, and oftentimes that med list is not right because they were last admitted a year ago. So that didn't happen with paper charts. So I think there's advantages and disadvantages. The other thing from a pharmacist perspective is a pharmacist is a lot more effective and safe in the hospital setting with electronic medical records than we used to be. And the reason for that is, if I was processing an order in the pharmacy and I didn't understand the order, it looked wrong, it felt wrong, my resources were to go to the chart. Mobile therapist has it, social worker has it, the nurse has it, physician has it. They couldn't find it, to somebody else's point, to get clarification. So I would have to call the physician or the prescriber, it would take time to get, so the order would be delayed, the patient's care wouldn't be optimal. With access to everybody's notes, everybody's labs, and this is extending even into the community, a pharmacist at Walgreens or at Kroger, some places have lab access in a very short amount of time. Those pharmacists are going to be able to pull up a patient's labs and use that information to determine if the medication is right. So there's no doubt that the pharmacist is more efficient, safer, more effective, a better practitioner with electronic health records.
Margaret Sanders, and then
Yes.
Margaret Graham. All right.
Go ahead. Either Margie. I just want to make a comment about the patient's perspective, because I have heard a number of older adults, particularly, or my age, and I don't quite yet qualify, but I'm close, who have said, the physician is no longer looking at me. They are in front of their computer. They are, and I feel, I have actually an older adult, very lovely, feisty lady who said, I jumped off the examining table, my gown flapping, and sat in the chair and said, please, look at me when you, so I think as a medical educator, we need to do a little bit better job of preparing our students and preparing our practicing professionals who are now using the systems, and we're never really trained in it enough. Trained in how to input, but not trained in how to deal with their patients while doing so.
Dr. Graham?
So in our nurse practitioner-led
Closer.
interprofessional clinic, we couldn't do without our electronic medical records, as many have said. We have tried to make sure that we have bucket 2 covered, so we have put in every patient we see for the first time, we try to find out, just to do a screening on their, so we do their generalized anxiety, we do a PHQ-9 to check their depression, and then we make sure that we have the preventive task force guidelines in, so that we make sure that we're hitting all of those things. And I think if we, so we've tried to build, we use the same system as the hospital because the majority of our patients come from the emergency room. If we did not have that, I'm sure we would be repeating lots of tests. So I think that it helps us give not only the care for the patients for what they're presenting, but we are really able to do a lot better preventive care. And then, as was said, we're able to do a lot more quality, pulling all of the data. But I do think that 2 huge disadvantages are having to go home and chart at night, and also then when you're not dealing with a system that's the same. The fact that we didn't hit that 2014 goal is really disappointing.
Thank you. If we can switch gears a little bit to talk about interprofessional education. IP is the big term today, and while many of us, probably most of us, espouse the concept of IP, how easy or how difficult has it been? What is your experience in working with interprofessional teams? Anybody want to start with that? Dr. Crompton?
Well, we just talked about that in our breakout session.
Oh.
And the fact that in the beginning, with this grant that we've been participating with Xavier, it took us some time to get to the point that we could move forward with the whole concept. So I think it is very foreign in a lot of traditional medical settings. And what I've seen is transformation. You know, we are working on this concept globally in public health, right? And so it's not a foreign concept there. But in the primary care practice, it does take time. So pulling home health in to be on the team, pulling the pharmacist in to be on the team, at the schools, pulling in a teacher and a social worker and the principal to be on the team involved a lot of changes in thinking. It involved a lot of barriers that we talked about. But at the end, now you're thinking about the whole person, and that's the goal. I mean, what it drives down to in a word is whole person care. And the things that we've been talking about with the electronic health record, it points to the same thing, that what we've got to really get to is not being absorbed in the processes and missing the patient. And interprofessional practice does that. So we are partnering both with Xavier and with the University of Cincinnati on a MedTap grant. So we've got the IPCP grant and the MedTap grant. And for us, it's been a tough process to get everyone up to the table, but the end result is fabulous. And what it's allowed us is to bring child psychiatrists to schools, to bring developmental pediatricians to the school setting, to open up communications, to have, and really for us as a newer federally qualified health center, what it's allowed us to do is develop more of a teaching space. And at the end of the day, that's what we've got to do, is we have to create that system change that says, just like those kids coming out of the training programs now are having no difficulty with the electronic health records, they have to think interprofessional collaborative practice if we're going to change health outcomes.
All right. Dr. Graham, you look like you're ready to pop in there.
So I have been a part of a HRSA grant where we actually started a primary care center that was interprofessional. And I can tell you, I think it's easier to start from scratch and hire all of the professionals, and they know when they're coming in that it's going to be interprofessional. We use the model out of Seattle that's called Team Care. And so it is a primary care setting, and we do provide care from cradle to grave. We identified the 4 highest prevalence chronic diseases in the area: depression, hyperlipidemia, hypertension, and diabetes. And any one of our patients that has any of those 4 things are managed by a team, and that team meets every Thursday. And so the 5% of our 3,000 patients are managed, and sometimes it's the pharmacist that's the lead, sometimes it's a social worker that's the lead, sometimes it's a nurse practitioner. And our patients love it. I mean, they absolutely love it. And our students love it. Our students want to be there. But it was easier for us than I think it is for most, because that's the way we started. You know, we didn't have to go into an existing system and talk people into this. When they came on board, they knew they were going to be delivering primary care in a team-based approach, and it was going to be a leveling playing field. You know, there was going to be no hierarchy or anything like that. And so it's worked great. It has been a great teaching experience, but I'm sure it would have been much more challenging going into an existing clinic.
Margaret?
Well, this past Saturday, I helped train 205 medical, social work, nursing, advanced practice nursing, exercise physiology, PT, nutrition, and pharmacy students. And it's been wonderfully successful. We've been using our HRSA Geriatric Workforce Enhancement Program grant money and Team Steps. So we are blending the two, and I have to say our biggest barrier has been finding faculty who would be willing to do a full day program from getting there at 6:30 in the morning and leaving at 6 p.m. But what we're doing now is we have some money that we've set aside to pay faculty as long as they do four training days and do some training themselves. So it's been really successful, and students have been. I had some students, an advanced practice nurse student said to me in the group that I facilitated on Saturday, this is the first time in my career that I have been with an entire team working through a case. And she said, and I love it. I thought, well, so it starts early, and if it starts early, then it's a lot easier, I think, to break some of the barriers later on.
I just have to share with you, Pat Heim, Dr. Patricia Heim, is a nurse who did her doctoral dissertation on gender differences in communication. She's written many books, and she has now a co-author also who writes with her. And she talks about the gender difference in team, in the understanding of the concept of team. And she said it starts when we're infants. And this probably affects most of the 50 to 60-year-old group, the youngsters. So, but she said, watch how babies are carried. Little girls are carried up over the shoulder. Little boys are carried like footballs. And for those who are 50 and 60, that's, if you can recall, that's probably how it was done with you. She said, boys learn sports, and this was before Title IX. They learn the lessons in sports, and one of the big lessons is how to lose and how to pay attention to your team. And at that time, the team was, I'm the coach, I tell you what to do, and you go do it. That concept is hard to get rid of in a team that we're talking about when it's not like. On the other hand, girls learn different lessons. She said, you don't lose at dolls, which is true. So, but girls learned negotiation, other kinds of interpersonal skills. And Heim's point was, when you get to the boardroom, there are going to be some serious differences unless you can understand each other. But I think our concept of team has been difficult for, oftentimes the physician is the captain of the team. And it's a burden on whoever is the captain of the team. Is it hard to give that up? Is it hard to convince others that maybe every time the patient comes in, the patient doesn't have to see the physician first? If the patient needs a physical therapist, you go directly to the PT. If you need a pharmacist, you go directly to the pharmacist. Dr. Eckler, can you comment at risk?
No problem. No, I think, yeah, I mean, it's, medical school now is 55% women, 45%. I mean, it's totally different than when I graduated. It was, 90% men. I'd never heard the baby football. It's interesting, but I can see. But, I think that Margaret talked about creating a practice, to go to an existing practice and try to talk about, well, the pharmacist, the term they use I love is embedded. The pharmacist is embedded. Yes. Like a war, with the 4th Marine Division, Afghanistan, because primary care is a battle. Yeah. So but we love to send them to the pharmacist, but who pays for that? Who pay? I mean, silly them, they want to be paid. And the social worker who I had a social worker one day a week in my office. Unbelievable luxury. Except when she was pulled to the hospital, which was way more important, than my and so you've got a grant, and but in private practice you have to generate income because these people want to be paid. The people that worked for me, I thought they should work for free, but they wanted to be paid. I mean, just go figure. And so all these team members that are so important, it's the logistics of how do you do that. That's all. I mean, I'm not saying it's not important and helpful. And I don't know that physicians are going to, it's not like, oh, well, I'm in charge. They want what's best for the patient. And you're right about the drug stuff and electronic. I mean, prescriptions were like wonderful with electronic. I mean, you know, and tracking, but you know, it's just how do you do that? How do you this team meeting she was talking about? You know, that I've actually been to, the huddle really. I mean, and it was and it was different providers, different times. A lot of times it was the pharmacist who took, but then they had the psychiatric nurse practitioners there. Those were, they would take the lead. You knew that was a problem, you know, when they, but it's how do you hire and collate and combine and pay and all, you know, this whole team. Now with value-based care becomes the norm and you're getting paid for results, you know, the idea is that, you know, big medical groups can have 10 practices can share a pharmacist a week. And a half day, that pharmacist, you know, we bring in our polypharmacy extravaganzas for them to deal with, or diabetic nurse educator. You know, a single practice probably can't keep a diabetic nurse educator busy enough, but 7 or 8 practices can, you know, and so that's what I think physicians will be glad to have that kind of help. It's just, how do you pay for it? I mean, how do you hire these people that, you know, that do that? So I think it'd be great. It'd be wonderful.
Great.
Yes, embedded. Just remember that.
All right.
So this isn't my field, so this is more like a question or a challenge to all you guys. And it's also blending the last diatribe about health IT, where, you know, I think we all agree that we need to wire the health sector and rethink the way we pay for it. And I think from a policy angle, it would have made more sense if we did the payment reform parts of the ACA before high tech instead of after. And I think meaningful use was constructed in part to solve problems that payment reform are better. You know, the only lever to push the EHR industry from a government perspective was meaningful use certification. So there's a lot of crap in there that people don't like, but it was the intent of the, you know, on behalf of the taxpayers to move that. And I think that the next opportunity is to hold up an expectation of the EHR vendors to support team-based care that's virtual. And so I would challenge the provider community to be really articulate about what that means. Because you're not always going to have the luxury of pulling, you know, people literally together for a huddle. And a lot of times you're working with a certain team construction for a certain population, different team for another one, in different locations. And we all see parts of our life where technology enables that kind of interworking and collaboration as a virtual team, and the EHR products to date aren't really architected to accommodate that use case. And you know, my final shot is that the provider community has been really good at complaining about EHRs, but really terrible at building roadmaps and saying this is exactly what we want. And so this is an area that I think, you know, the EHR vendors are very responsive to the market. And so Ohio is the largest footprint of Epic in the world. And if all the health systems in Ohio on Epic decided that they wanted EHRs to track, you know, what kind of salad dressing patients are eating, Judy Faulkner tomorrow would tell her staff, figure out a salad dressing algorithm and build it in Epic. They would be highly responsive. So again, it's just a challenge. Figure out how you're going to manage teams that aren't all physically co-located using technology.
So one of the interesting things that I get the fun to work with is that hopefully people by now have heard about direct primary care. So it's concierge for the working class. The good news about direct primary care is they've been able to eliminate, for the most part, third parties. So it's the team or the physician and the patient paying a monthly membership fee. And what happens when you remove the third party intrusion with what I call the meaningless use and all that kind of stuff, that's large enough now that has attracted some EHR vendors who have designed platforms for that practice, which means you own, in the old days, when I started with Family Docs in Hershey, Pennsylvania, it was a 3x5 card in a box, and people would put down what they needed to remember about that patient, and the rest went up here. And by the way, Barbara Starfield documented the high quality and the population benefits of that level of care way before IT. At any rate, these platforms are being designed by and with these docs And they're now connecting up with virtual systems. So there's one based in Columbus, Ohio, that I just discovered a few weeks ago at the Ohio Association of Community Health Center meeting, and it's called Excite, and it's a web-based virtual system that'll communicate with any EMR, and the primary care, subspecialist, PT, hospital can all input data around the patient, and the patient has access to that data. It's like, wow, this is just way cool. But in that space where you don't have to get, what is her name, Judy Faulkner, to her, whatever, to come up with the new algorithms, there's a much more responsive IT community out there that's beginning to do this. It's very exciting to see.
Go ahead, Dr. Crimpton.
So one of the things I was going to talk about is work that we are doing with Children's Hospital and their strategic plan 2020. They have one of their pillars is community connected primary care. And so that's the one that we've been working on, and I think it sort of drives toward that concept. One of the things that was very down to the base that we did with their Epic system is they said, what do you want to do? And we said, we think that registration process should put the name of the school with a phone number in the electronic health record. Well, how often do y'all want us to recheck it? I don't know, you tell us. How about once a month? And so we are now testing that process, and what it's doing is creating a connection between the family, the hospital, and the school now, because most of the time the providers are outside of knowing that. And what we were seeing is children leaving the hospital on medications that they never got the prescription filled. So I think that there's great opportunities for innovation if we look at what would make children and adults healthier, then we can sort of walk backwards like this. So we're really excited with that one little test of change. And I'm excited about bigger tests of change because we are seeing improvements in asthma control, in the psych management of kids. And by the way, we're in a pretty serious crisis in this community with mental health problems for adults and children, but for children, it's at a crisis level that is equated to suicide. And I think we need to be mounting more of a response. How do we build that into the system that there is the right alerts?
Dr. Hine, you looked like you were ready for something there.
Right. I kind of forget what my points were. I did have some good ones, but I can't remember what they are now. But so I guess I had two comments. I think the first comment was, going back to the embedded. How do you embed yourself on a team that already exists? So the pharmacist, I think is a good example, and there are probably other disciplines too. That you have to prove that you're valuable, that you bring value to that team, right? And so you have to be willing to do it on the side. They're not going to hire somebody just in case you're valuable. You have to be able to see an opportunity, jump in and take it, prove that you're valuable. But then the key really is and this is the academic side of me, the publication, the scholarship, the announcement of adding a pharmacist to a critical care team cuts the length of stay in the ICU by a day and a half. Right? I mean, if that data exists, it's a heck of a lot easier for that next hospital or that next institution to add a pharmacist to the ICU team, right? I've been fortunate enough to be part of a palliative care team, and palliative care, if anybody works in palliative care, you can't have a palliative care team that's not interdisciplinary. It doesn't work. And so palliative care at my institution was started from scratch, and it was very easy to make it interdisciplinary because it was from scratch. I've embedded myself into an internal medicine team that didn't have a pharmacist and really lasted for 20 years without one. Why do I need one now? And so had to prove, why that is the case. And a lot of that is the posters, the publications, the data, so that when you build that business plan, the next time you want to embed yourself, you've got something to fall back on. And then just a quick point about the faculty comment around interprofessional education. So colleges of pharmacy, medicine, nursing, allied health, pretty much all the representation that we have, in the audience. It's only been relatively recently that those colleges and schools have been required to do interprofessional education from an accreditation standpoint. In the past, it's always been these sort of a la carte options, right? We've got this event or that event, and if a student does it, they get some credit, or they get bonus points, or they get a feather in the cap, or whatever. What needs to happen is that students need to be exposed to interprofessional education, interprofessional teams, the very first year that they're in whatever profession they're studying to be. It can't be when they get out into their clinicals or their externships, or whatever we call them, that they're exposed to interprofessional teams at that time. And interprofessional education isn't sitting in an A&P lab with nursing and medical and pharmacy students learning from a physiologist, right? That's not interprofessional education. That is not what the intent is. And so the barriers to that are very numerous and profound, and been working, against them for years. Funding, who's going to pay for these events? Curricular alignment, working with a College of Medicine who's kind of on their own curriculum, which isn't a slam, it's just they do their own curriculum, and the rest of us have different curricula. How do you align one course across those four schools at the Academic Health Center at UC? Faculty development. How does a faculty member who has interest in professional education get involved? What do they do? How do they learn? How is their time accounted for? Who's keeping track of their hours? Is this going toward their promotion, to their tenure? Are they getting paid extra for it? At most places, the very good people do everything, right? So most of your interprofessional education in colleges and schools are done by a very small, powerful group of people who are doing everything else for their colleges and schools. And so you get burned out and you don't have enough resources. So a lot of that goes back to development, faculty development, and that costs money to bring in speakers and things like that. And so you have to have a dedicated budget for that. So I think those are the things that from an academic standpoint, colleges and schools are challenged with, to expose students to IPE right away, right when they enroll into a program.
Yes.
Can you hear me now? Yep. Okay. Okay, I have a comment. I work in the emergency department in my free time, and I think that we do a really good job of interprofessional collaboration. We also have a pharmacist. But one of the things I see as an ER nurse is that the community is not educated on roles. And when a pharmacist comes in to do a medication reconciliation with the patient doesn't even acknowledge that that's a pharmacist trying to help them, reconcile their medications. And another side to that is, we focus so much on patient satisfaction and magnet and those types of things that the patients expect to see a physician when they go to a visit. If a pharmacist comes in, they don't understand that you're there to help them with their medications, or a social worker comes in, without educating them, they don't understand that you're there to help them with their follow-up care or whatever, you're consulted for. So I think one of our big problems in the community, especially Cincinnati, is lack of education, throughout the community.
Dr. Graham, you work with a whole interprofessional team. You created this team. You initiated the concept. How can you respond to that? Does the patient expect to see a physician each time?
They can't expect to see a physician because we don't have a physician on site. It's a nurse practitioner-led clinic, and the physician is they're consulted, but we never have a physician on site. So the patients who come to us are primarily sent through the emergency room, but now they're being sent to us by their family and their friends because they like the care that they get. But they do learn from day one that they will be seeing. So it's, I think, exactly what you said. It's the education part. They know, our diabetics know that many times the person that they will come and they will probably see the pharmacist and the dietitian, and that might be the people that they see for their visit. to Pat's point, that would be difficult to charge for. I mean, we are able to charge for some of those visits, but it would be difficult for us to run that clinic if we weren't sustained by some grant funding. I mean, we're doing much better now with our collection because of the ACA and things, and we have more people who are insured, but we do educate from day one. We educate them that it is a team approach to care. They will be seeing members of the team, and we, you know, like our diabetics will know their primary care provider. They may know our psych mental health nurse practitioner or our social worker. They will certainly know our dietitian, and they will know our pharmacist. So they may not know every member of the team, but they'll know the member of the team that will be working with them the most. And it's primarily through education, but they like it. You know, they really they like seeing the different people. But I think if they weren't educated about it, then I think that it would be, you know, why am I taking all this time? So I think it is, your point is well taken. We have to educate them that there's many people who will help take care of them.
Larry?
So call me old-fashioned. In the old days, when people walked into a room, they introduced themselves. I've taken family and friends to ERs in different cities, and people just walk in and they start doing things, they start saying things, and I'm pretty knowledgeable, and I have a hard time figuring out who they are and what the role is in all of this. So I do think it falls to the team members, and particular in this case, because of our culture, for the ER doc to say, okay, this is how we do things here, and kind of explain the role so that the person, number one, they're either unconscious or they're confused or anxious, and the people who are with them are trying to support. So they're not at their best in terms of their cognitive processing at the time. But I do think it's the team's obligation. The other thought is, you know, get the script writers for Scrubs and what are the other TV programs now, and that's how you educate the public and change the culture. And I'm really serious about that.
Dr. Eckler, you were one of the initiators of the results of House Bill 198, which was passed back in, I can't even remember when. 09. Seems like forever ago. It was forever ago. You've been part of that PCMH Task Force Advisory Group forever. Talk a little bit about the education component that was very different in that bill that isn't usually in most PCMH bills.
Yeah, there were 50 practices around 4 areas of the state were picked out in House Bill 198. And it was actually Representative Peggy Lehner, who's now Senator Peggy Lehner, and Ted Winslow, who kind of came up with this idea of actually transforming practices to medical homes, certified medical homes, and did not use Cincinnati, Columbus, or Cleveland because the medical home movement was kind of ahead of the game there. But the Dayton area with the med school and the nursing school, the Toledo area with the med school and the nursing school, NeoMed with the med school, 2 nursing schools, and then OU with the med school for Southeast Ohio. And so curriculum, Jerry was actually the chair of the curriculum committee. We wrote curriculum that what we thought medical schools and nursing schools should be teaching. We actually have some of that in our slides for our workshop that we did this morning. But then the other part of that was 50 practices were transformed around the state in those 4 areas. And the idea being that those would be sites where students could then work, so that was what's kind of different from this, is that we actually went at the practice level. About 44 practices stayed into the program. About 3/4 of them actually did get certified mostly by NCQA. So right now what we're trying to do is see what they're doing with students. Are they really working with students? The first group of physicians that has been sponsored in this graduates this June. They will be finishing residency. And so part of the deal for the $30,000 a year support that they got was that they have to practice in Ohio for 3 years in a primary care site that takes Medicaid patients. And so we now we will now have students graduating. We are trying to track down where are they going. It's interesting, the Board of Regents, which is now the Ohio Department of Higher Education, doesn't track these people by name. It's NeoMed 3, 2, I mean, so we're in the process of trying to figure out who they are. The nursing schools have been turning out people every year. Okay, they've had 30 graduates over the last 4 or 5 years, and we're now
Advanced practice nurses.
Yeah, advanced practice nurses who are practicing somewhere in Ohio. So we're right now actually this week tracking down who all those people are. And Tom Dilling, from the Board of Nursing, who's on our steering committee, assures me that he can tell us where they are. Okay, all he needs is a name, and he'll find them. So because the idea is if they're not meeting their obligation, they owe money back to the Ohio Department of Higher Education. So we think they're all practicing in Ohio. But it's going to be interesting to be able to say, here's 13 or 14 or 15 physicians going into practice in Ohio who've been under this medical home curriculum. We actually checked with the medical schools. How are they implementing the curriculum? How are they teaching it? The biggest problem we're seeing is that the practice of medicine needs to change to be more attractive to practitioners. I mean, they owe a lot of money. Not that that's the sole driver, but when they see doctors taking charts home at night to finish them, they just don't, they don't find that to be it. So that's being worked on, and I think there's going to be success there. I think that with scribes and better EMRs that are, are more, which have a registry function, and doctors help. He's right about doctors like to complain about it, but don't do anything about it. Although, in some situations, it's an employer with 100 physicians that's buying the system. So anyway, but I think this program will be interesting because we're going to start putting people into practice. We can track where they are. We can tell Governor Kasich is very interested in and aware of this program. He views healthcare access. Jeff Beal from Columbus talks about not a healthcare system, but a healthcare situation. I think that's great. And he actually made that term up. I thought he stole it from somebody. But, we have a situation right now. And so I think that the governor is very interested. He views healthcare as an economic growth factor. Jobs are not going to come to Ohio unless there's good healthcare. And so, now getting it paid for and getting people access and insurance. And, we were talking about that the OB congressman from Oregon who said there's no problem with access. In America, there's the emergency room. That's like, yeah, that's great. So anyway, but that's been an interesting project, and it goes on. Actually, our funding ran out in 2014.
A long time ago.
And we continue to
We
meet.
continue to
We
meet.
continue to meet. Our steering group meets 2 or 3 times a year, and people are still. And we got representatives from all of the nursing schools and medical schools and the Board of Nursing and State Medical Board. And
So
it's been an interesting effort that I think will start to pay some dividends because we've got a pipeline now full of new physicians and new nurse practitioners that should be helping meet
So
the
this
need.
was one of those government-funded solutions. It was 3-pronged to enlist patient-centered medical homes practices to move from primary care to PCMHs, which are different because of the team effect, to provide scholarships to medical students and advanced practice nurses to entice them into working in PCMHs, and then the educational component, which was to develop a curriculum by which we could educate the practitioners. So it's an evolving process. It's been going on since '09, and it will continue to go on as long as the steering committee and the advisory committee continue to meet voluntarily.
And it keeps getting funded by the state.
Right, yeah.
Which so
Who
far,
knows?
we're fine. We made it through the budget process this year and was not cut.
All hope is not lost. That's right. Does anyone on the panel want to ask any other question? And if not, I'll throw it out to the audience for just a few minutes. No? All right. Let's thank our panel. They've been really good. And if you'll hold your places for a few minutes, we've just got about 5 minutes. If anyone in the audience has a question, if you could raise your hand, we'll get you a microphone so that we can all hear your question. Yes, over here.
Okay, so mine is a quick comment. I'm a nurse informaticist at Cincinnati Children's. And so when you were talking about EHRs, I was itching, I just have to tell you. But we're really working right now to streamline how we use the EMR. The EMR, of course, I think our workflows have been designed based on what the EMR provides and not the other way around. And so most of our disciplines work in silos within the EMR. So my team right now is leading an interdisciplinary design team to create a one interdisciplinary admission process and actually getting the questions to the professional who is kind of responsible for that. What we've learned is that nursing was asking a list of questions. I think there were 220 questions in our admission navigator with 544 choices in those 220 questions. And we were asking questions on behalf of child life, on behalf of OT, PT, nutrition therapy. And so when we pulled these providers together over the last 5 months, what we learned is I didn't even know you were asking those questions. I wouldn't know where to go and find the information that you documented in the first place. And why should you be asking that on every patient if I'm seeing them? And so we've got like some seriously soft prototypes right now, but we're gonna be redesigning workflow to get us to that interdisciplinary team so that there's a launching pad. And there are some, in Epic, there are some tools that make this kind of possible, that continuum from community into the hospital, and then episodic focused information to where everybody launches from the same the page and sees the same information. So we're actually sharing the data for the patient.
Thank you. Well, kudos to you for that. Anybody else have a question? No? All right. Well, I think our panelists have helped us understand that it's a process. It takes some time to develop. There are some barriers, but there are quite a few solutions, and I think from some of the solutions that we've heard here, we can borrow from each other. And oftentimes it just takes someone to ask a question. Why are we doing it this way? Or why aren't we doing it some other way? And Janice, you're a good example of that. So is Margaret Clark Graham. I think all the panelists have done that. They've asked the pertinent, relevant question. And if you can't find an answer real quickly, sometimes you have to develop yourself. So thank you again, panel. And thank you, audience, for sticking around, for participating, for listening well, and for asking your questions. Susan?
We also want to thank Dr. Milstead for being the moderator here. And next month, I'd like you to think of her when she celebrates her 81st birthday.
Yeah. They come around too fast.
No, she's fabulous, and being an international leader as she is, it's wonderful that she's here with us and guiding us with her terrific wisdom and such. And I want to personally thank all of our speakers here, and Kelly and Nora and Tracy who are out in the audience. You all have been wonderful. I just keep hearing all day from our audience how great you all are. Mm-hmm. So thank you so much. And now I want to thank Sharon DeMario, Denise, Kelly Lyle, Sarah, Lisa Niehaus, all the folks who were on the committee with me as we put this together from across the state, and the committee that Pat is on, and Jerry and I am on in Columbus, the OPCPCC.
Yes, et cetera, et cetera, et cetera.
They all have been participating over the year in designing the conference. So thank you guys too. Okay, little break and then breakout session, and then have a safe trip home.